Hi friends, welcome to classes by Lab Doctor. I am Dr. Divya and in today's class let us discuss about hypernatremia. Sodium levels आपके blood में ज़्यादा हो जाते हैं more than 145 milli equivalents per liter, then it is called as hypernatremia. अगर ये सोडियम का वैल्यू more than 160 milli equivalents पर हो जाता है, then it is very severe. It's a critical value for sodium wherein you will have to inform the clinicians. So, जो सोडियम का लेवल रहता है दैट इज बिटवीन 135 टू 145. अगर 135 मिली इक्विवेलेंट से कम है दैट इज हाइपोनेट्रीमिया. अगर 145 मिली इक्विवेलेंट से ज्यादा है देन दैट इज हाइपरनेट्रीमिया. सो इसको हम क्लासिफाई कर सकते हैं माइल्ड, मॉडरेट एंड सीवियर. माइल्ड व्हेन द लेवल इज बिटवीन 146 टू 149, मॉडरेट व्हेन इट इज बिटवीन 150 टू 169 एंड सीवियर इज वन इट इज मोर देन 170 millimoles per liter. So you all know that this sodium is controlled by many of the hormones in our body. It can be antidiuretic hormone which will what it will do, it will prevent the diuresis, antidiuresis. So it will retain the sodium, it will retain the water, it will increase the blood pressure. It could be the renin-angiotensin system wherein whenever there is a drop in blood pressure the renin is released from the kidney and this renin helps to the conversion of angiotensinogen to angiotensin 1 to angiotensin 2 and that activates the aldosterone from the adrenal gland and this aldosterone helps in the reabsorption of the sodium and water. So remember these hormones, this renin-angiotensin system, the aldosterone, the natriuretic peptides, all these are important to maintain the sodium homeostasis. So you all know that the body fluid is divided into extracellular as well as intracellular compartment. ये जो intracellular compartment है that contributes up to 40% of the body weight और 60% जो है वो ECF रहता है and sodium जो है it is mostly concentrated in the extracellular fluid, to be specific where in the interstitial area. So you will see that whenever there is hypernatremia, I have told you कि plasma osmolality क्या है, it is 2 times the sodium. It is the concentration of the solute in the fluid. If there is hypernatremia, automatically the plasma osmolality बढ़ जाएगा. So this is also important. Whenever there is an hypertonic solution, अगर solute का concentration ज़्यादा है, आउटसाइड में ज्यादा है सोल्यूट कंपेयर टू इनसाइड द सेल, क्या हो जाएगा, जो भी सेल्स जो भी वाटर है इनसाइड दिस सेल इट विल स्टार्ट मूविंग आउट क्योंकि यहाँ पे सॉल्ट्स का कॉन्सेंट्रेशन ज्यादा है तो वाटर विल फॉलो दिस सोडियम, इट विल स्टार्ट मूविंग आउट तो ये सेल श्रिंक हो जाता है. सो दिस इज what happens in hypernatremia. और hyponatremia में मैंने बताया था आपको यहाँ पे सोडियम का कॉन्सेंट्रेशन कम है. जब सोडियम का कॉन्सेंट्रेशन यहाँ पे कम है कंपेयर टू इनसाइड कॉन्सेंट्रेशन ऑफ सोडियम, ये जो वाटर है इट विल मूव इनसाइड क्योंकि यहाँ पे सोडियम ज्यादा है ये इसको फॉलो करेगा तो द सेल विल स्वेल. That is what happens in hyponatremia. Whenever the sodium concentration goes more than 145 milliequivalents, we term it as hypernatremia. Now it could be because of increased water loss. आप ज़्यादा से ज़्यादा water lose कर रहे हो, that is why the concentration of sodium is getting raised, or you are taking less of water. The water intake itself is less, that is why the sodium must have risen, or in rare cases you are consuming excess of salt which can cause hypernatremia. Etiology of hypernatremia में it is one is either you are gaining sodium or there is lack of water intake or there is water loss. So I've told you water loss could be because of breathing, sweating, vomiting, diarrhea, or it could be renal condition which can cause water loss like diabetes insipidus. अगर osmotic diuresis है that can all cause water loss and that can increase the sodium concentration. Suppose if the patient is not taking adequate water और if the patient is gaining sodium like excessive salt ingestion है या उसको hypertonic saline infusion कर दिया है, or the patient is having some kidney issues like he is gaining renal sodium gain because of hyperaldosteronism, hypercortisol, all this will cause increased sodium. So it is mainly either you are losing more of water than sodium. अगर आप ज्यादा water को lose कर रहे हो than sodium तो sodium का concentration obviously बढ़ जाएगा, या आप ज्यादा sodium को gain कर रहे हो compared to water then also there will be increased sodium. So whenever the sodium is more than 145 milliequivalents per liter, you will have to evaluate the contributing factors, as I have told you, whether the patient is losing water, whether it is because patient has lost more water, that is why the concentration of sodium is getting increased. We have to evaluate that. Now when the patient is losing more water, he can lose water from where? One is the insensible, wherein we cannot sense that water loss, like fever hai, he is in a very high temperature, he is doing exercise, a lot of sweating, there is burns, respiratory illness, he might lose a lot of water. That is an insensible water loss. Gastrointestinal tract diseases, patient is having severe vomiting, severe gastroenteritis, severe diarrhea, osmotic diarrhea, patient ko malabsorption hai, that time he can lose lot of water, that can increase the sodium concentration. If suppose there is some kidney issues, like patient is having diabetes insipidus, there is increased amount of water which is lost from the kidney, then patient can have increased sodium. Patient is having hyperglycemia, he is taking diuretics, all this can cause increased water loss. And I have told you there is decreased fluid intake, patient is not taking enough water, so the concentration of sodium will rise. Now why patient is not taking increased fluid intake? There could be some neurological impairment, hypothalamic disorder can be there, he might be on fluid restriction, yeah, there might be ineffective breastfeeding in child, that's why there is little water which goes to the child and the sodium level of the child might increase. Third is I have told you excessive sodium only. Excessive sodium ही in administer हो रहा है patient को. We are giving him hypertonic sodium chloride, or we are giving him normal saline, we are giving him blood products. All such things can also increase the sodium concentration. I have told you that there are few of the hormones which maintain the sodium homeostasis. One is aldosterone. So in case of primary aldosteronism, that is in adrenal insufficiency, in this primary aldosteronism, it's also called as Conn's syndrome. So on the, you can see that this is the adrenal gland and there is a tumor here. So this, because of this tumor, there is increased secretion of this aldosterone. So what it will do, it will increase the sodium level, it will increase the absorption of the sodium. So the sodium levels will be very, very high. So that can cause increased sodium. In adrenal hyperplasia, there can be increased sodium. In case of Cushing syndrome, there can be increased sodium. In diabetes insipidus, so in diabetes insipidus, what happens? The passage of unusually high volume of dilute urine is there. So there is increased loss of water, which is more than 3 liters per day, and that can lead to increased concentration of sodium because less of water in the body. So whenever there is increased sodium, whenever there is sodium retention, we call this as hypernatremia. So whenever there is hypernatremia, it causes extracellular hypertonicity. Water will move from ICF, intracellular fluid compartment, to extracellular fluid compartment. That will cause intracellular dehydration. This is the hallmark of hypernatremia. The brain will shrink, result in intracerebral and subarachnoid hemorrhages. Central nervous manifestation, patient will be irritated, patient might have seizures, patient can go into coma, etc. Whenever the renal tubular cells are shrunken, there will be acute tubular necrosis. Patient can have oliguria, he can have low urinary sodium, he can have elevated blood urea nitrogen, serum creatinine, etc. So this is the manifestation of increased sodium. So I have told you, in the brain you can see the cells will shrink. So because of the movement of the cells from the brain cells, the water is moving out. So whenever the patient is having hypernatremia, we need to assess the volume status of the patient. Patient क्या euvolumic है, hypovolumic है कि hypervolumic है. Depending upon the volume status, his BP, his pulse, etc. will vary. Suppose if a patient is hypovolumic and there is hypernatremia, I have told you there is increased water loss, and because of this the sodium has increased. So this can be because of kidney causes and extra renal causes. अगर extra renal causes है like vomiting है, diarrhea है, so increased sweating है, burns है, उसके वजह से हो रहा है तो kidney will be functioning normally. So sodium excretion of the kidney will be less than 20. But अगर because of kidney cause only, like kidney में अगर diabetes insipidus है, like kidney में अगर osmotic diuresis है, patient को diuretic दे दिया गया है, so here the kidney will not be able to absorb that much of a sodium, so the excretion of sodium will be more in the urine. Similarly, in case of hypervolumic hypernatremia, like in case of salt water ingestion or primary aldosteronism, in Cushing syndrome, what happens, the volume of water is more, and along with that there is increased sodium. In euvolumic hypernatremia, what happens, like in diabetes insipidus or hypodipsia, decreased thirst and all, the volume of water will be almost normal, but there will be hypernatremia. Hypernatremia, I have told you, suppose if the patient is hypovolumic, patient will have hypotension, low blood pressure, tachycardia, poor skin turgor, and in euvolumic patient might have normally, may not have any much of the symptoms. He might have normal pulse, there might be no edema, blood pressure also could be normal. And suppose if he is hypervolumic, then the patient will have edema along with increased sodium. So I have told you, in an acute hypernatremia, patient can get CNS symptom. He became restless, confused, lethargic, irritable. There might be convulsions. He might be unconscious. Muscle weakness might be there because sodium is required for the muscular function. Patient might have nausea, vomiting. You can see an MRI in hypernatremia. There is a shrinkage of the brain, and because of which there is intracranial hemorrhage. The treatment also depends upon the cause of hypernatremia. Whenever there is an hypovolumic state, we will have to give the fluids and correct it. Whenever there is an volume overload, we might have to give a diuretic, because hypernatremia is not a disease. Hypernatremia is a manifestation of other diseases. So there can be so many conditions which can cause hypernatremia. We will need to evaluate the patient's serum sodium, the urine sodium, the volume status of the patients, etc., and then find out what actually is causing hypernatremia and treat the cause to maintain the normal levels of sodium in the blood. So that is all about hypernatremia. Thank you so much for watching the video. Please like, share and subscribe the channel. Thank you.